I'm not sure I like this idea of walking around, but I don't like to deviate from the norm, so I'm just gonna go with it. Yeah, she's proud. So thank you for the opportunity to talk today. I'm gonna address an issue that I think have been a bit like the neglected child of the medical education. I think we don't know much about continuous professional development. And I think we should really pay a bit more attention to it, and that's what I'm going to try to convince you of. I think it's important for us as professionals, but it's also quite important for our patient. So what is continuous professional development? So in theory, and that's the kind of definition you're going to find in the literature, it's an active and self-directed lifelong learning grounded in reflective practice. So what does that mean? Well, active means that sadly it's going to take some effort, right? Self-directed means that we're going to have to establish some goals so that we can accomplish something. And reflective practice means that there's going to need to be some time dedicated to it. So these are kind of key ingredients of continuous professional development, but sadly there's also part of the challenges related to that process. So I don't think I have necessarily to convince you that lifelong learning is needed. I think we're all very aware how fast the knowledge and the skills are evolving in our field. And actually there's some literature saying that we're not staying competent as professionals for more than 4 or 5 years. And sadly, because of the nature of our practice, there's also an important decay in our skills and knowledge, especially for the things that we don't use on a routine basis, but that may be required someday depending on the patients that roll in the unit. I think, and I'm not going to spend a lot of time on this because a lot of my previous colleagues and in other presentations that you've seen throughout this conference show that there's certainly room for improvement. There's a whole body of literature about patient safety, medical errors, lack of knowledge translation of the literature. I was at the neurology sessions previously showing how the guidelines are not being well implemented. And I think that's just a symptoms that there are some important gaps in continual professional development. And there's also what I call the family member question. So intuitively, there's all colleagues that we're working in our environment, not a lot, it's just a few of them to whom we wouldn't necessarily refer family members because we feel that there are some gaps in their competence. So in order to try to convince you of the importance of paying more attention to CPD, I'm going to briefly discuss what I think are the roots of the problem. We're going to quickly look at what other fields are doing in this area, and then we're going to discuss a little bit of ways forward to try to promote professional growth. So as healthcare professionals, we're all expected to engage in self-directed learning. And this is not necessarily an easy task, and I think it's really important that we recognize the challenges so that we can actually properly address them. So I presented here what are, at least in our system in Canada, the 3 key CPD players, and there are actually challenges that are related to each of them. So I think primarily because we are, again, as I described in the definition, it's a self-directed process. So as healthcare professional, we are individually primarily responsible for that process. And that's where we're going to start. So there are a couple of assumptions that go with individual professional-driven CPD system, which is mostly what is happening right now, at least in Canada, but many other countries. So it assumes that actually as a healthcare professional, we have some insight in what are the gaps in our practice, how we compare to others, what are our strengths and our weaknesses. It also assumes that we can then engage purposefully in some learning activities that will help to fix those gaps. It also assumes that we have the motivation to actually engage in lifelong learning. And finally, it assumes that we have some time and energy, I would say, to engage in this process. So the problem is that there's many things about those assumptions that are really problematic based on what we know in the literature. So one of the big problems is that all the literature about self-assessment says that we're really bad at it. So some of those studies have been summarized in this paper from Davis, that is to your left, I guess. And it's not only because we are physicians or exceptional or specials. As human beings, we're just not good at self-assessing, and we just need to accept that. And there's a bit of an alternative view that is presented with this great paper from Eva and Regier that try to make the distinctions between our ability to overall to assess our performance and compare to others, which is also bad, according to them. However, we have a certain ability to certainly predict how we're going to be able to accomplish a certain task in specific circumstance. And they describe that as self-efficacy, and is a little bit different, but not the most useful skill to develop a learning plan as part as lifelong learning strategies. So in summary, we're pretty bad at self-assessing, and that's why both a group of authors actually argue for the importance of getting external data on our performance to be able to inform our assessments. There's also what I call the problem of agency. So in social science, agency means our ability as humans to act independently and to make some free choices, which is a great concept. The problem is we don't always make the good choice. And actually, there's a fair bit of literature that shows that as healthcare professional, we tend to engage in learning activities that are within our zone of comfort because they require less effort and because we get quicker rewards. So, and again, it's not just to blame ourselves and trigger any guilt in you. It's just to say that often we don't have a lot of energy, we're quite tired, sometimes we're a bit lazy, but really that's just, again, a characteristic of human beings, right? So although we're not very insightful, I think we have a good knowledge of what are our needs in a way that we know our practice and the kind of patients that we take care of, and that can certainly inform CPD. We have an agency, and therefore when we design CPD strategy, we need to make sure that people will be willing to engage in the type of activities that we're going to propose. I think we should not underestimate our genuine interest in caring properly for our patient, and that should certainly be the source of motivation of those activities. And finally, we need to recognize that we have competing priorities. We're not full-time students anymore, and as Francesca mentioned at some point, we need to move on in life and get kids and do some travelings and do other things, right? So really the individual professional are a key factor or a key component of CPD, but it's not sufficient. We need help, we need support to be able to maintain or to engage in lifelong learning. So in pretty much every country, and certainly in Canada, there are some regulatory bodies that are also partially responsible for CPD. So in Canada, we have the Royal College of Physicians that Alison talked a fair bit about, that take care of postgraduate education, but also post-certification, maintenance of competence. And there's also licensing body that have some regulatory function. And it's important to understand that the main role of those bodies is actually accountability towards the public. So we are a self-regulated profession, and therefore we need to maintain the trust of the public, right, towards our profession. And there's different ways to do that, right? It can be to provide incentive to professional, like the carrot, or it can be to provide punishment to the professional who do not engage in maintenance of competence, and that can be the stick. And in Canada, the program is actually doing a bit of both. So we have this, so I put an example of my, what you call main port with the Royal College, where you actually have a cycle of 4 years, as you can see at the top there. And then as you can see in the little quadrant on the right, there's actually credits that accumulate. and you need to reach a certain amount of credits by the end of the cycle, by the end of 4 years. So it's not that hard, as you can see. So that's in a year, I actually got what's 160 credits. So I'm well on my way to reach my target. And the credits usually represents hours of continuing professional development. And there's different type of activities that as you can see to the bottom right, where you have section 1 and 2 that are group learning and self-learning activity. And there's a section 3 that's our assessment activity, and keep that in mind because I'll come back to those, for which you get actually bonus credits, so that for every hour you get actually 3 credits. So those are good to reach your target. And this system has actually, there's been multiple iteration and a facelift. That's not me getting a facelift, that's the program getting a facelift. But yet it still doesn't seem to be achieving what it's meant to be. And in actually an interview-based study that the Royal College themselves did of their member, most of the physicians unanimously almost report that this was not really helpful. That was just an add-on to the already multiple things that they have to do, and that they don't feel it really helped for their practice. And it's also important that this kind of system is actually based on attendance or reported attendance, but not necessarily what is learned or change in behavior, right? So me being here, I could be on the Singapore flyer for 2 days, and I would still have my credit for being here for 3 days, right? That would be a long run on the flyer. So other places in the world, like our neighbors from the South and the States, have been trying to be much more prescriptive in their maintenance of competence for their physician. And they actually had a huge pushback from their member, and they had to backtrack over a few years to drop certain requirements that they had imposed to their member. And I think the quote that summarized the best this is from the Medscape News, saying that in a policy retreat longer than Napoleon March from Moscow, the American Board of Internal Medicine once again has relaxed its controversial requirement for maintenance of certification. And I guess the biggest complaint is that this whole system that was quite demanding and required and mandatory to maintain your certification in the States was not based on much evidence, was very time consuming, was again felt not to be helpful by the healthcare professional, didn't show strong evidence of validity, and was really run and implemented as a business model where people felt they had to pay a lot and we're not getting much back. So that actually fell apart pretty quickly. So there are actually a lot of activities that are promoted by those regulatory bodies that are not necessarily the most helpful, but an organization like the Royal College doesn't provide a lot of CBT activity themselves. They often are responsible for accrediting activities that are provided by a third party. So let's look at this third party that I call the CPD Providers, and it can be different things like professional associations or others. So the CPD Providers usually really like very traditional forms of CPD activity that are mostly based on lectures or conference, like today, or other form of very passive strategies of learning. The content is also usually established by the organizer of the activity and not often based on needs assessment that reflects the needs of the audience that they're trying to address. And there's also a huge variability in the quality. And there's a lot of literature about traditional CME activities out there, so I provide a few examples. And there's an interesting one that says that actually looked at all the web-based activities available, and there's more than 136 websites out there that are kind of relevant for critical care. So lots of resources, but also a lot of variability in the quality. So as a consequence, I always laugh when I present this at a conference because obviously you may not take on much of what I'm saying right now, but that's okay. So what we saw so far is that in practice, continuing professional development is not really active. It's actually often quite passive. And it's really hard and shouldn't be only self-directed because we're so bad at self-assessment. What about being reflective? Well, we might come back to that in a bit. So first, I would like to actually look at what is being done in other fields other than medicine. Oops. So I actually borrow from the field of music and sports, and I heavily borrow on a series of papers that were actually published by Chris Watling, who's a medical educator researcher from London in Ontario, who's actually, as his PhD work, compare other domains such as music and sport. But I think they're a good example for medicine because they do require learning from their professional throughout their life, like musician has to learn new pieces, I guess, and learn to work for new equipment if you're a sportive person. So they have lifelong learning involved, and they're also are often based on collective performance. So what do they do different than in medicine? Well, first, they practice a lot, right? They spend a lot of their time practicing, and the practice is really separate from the act of performing. And it's timely different, but it looks very much the same. If an orchestra practice a piece, it's the same thing as doing the performance. There's also, regardless of the level of performance, there's lifelong guidance throughout their profession. Like a professional tennis player doesn't get rid of his coach because he's been playing tennis for 10 years, right? And there's also both individual and collective learning happening. So, you know, the sportive and musician, they practice in private, and then there's also collective practice. In medicine, we do things a little bit differently. We don't practice a lot. And when we practice, it's often outside of the clinical environment. And what we do, like right now, looks very different than actually the performance. We also have minimal guidance post-certification. So we go from a very structured curriculum with objective, resource, outcome, with regular assessment, even more assessment now as Alison presented, to basically nothing. Very unstructured. There's no curriculum at all, and there's very little assessment. And when we get feedback, it's often collective, and it's often extremely high stakes because all of a sudden your licensing body decide to review your practice, and that can be big trouble if there's problem with that. And now you're going to say, well, what about, you know, we're learning throughout practicing. Like, you know, we learn in our clinical environment. I take care of patient. If I don't know, I go read, and then I come back and apply that. So that's fine. But I would just refer to those two papers, which I found quite interesting. The first one is more a commentary by, again, Glenn Regiri and Maria Milopoulos, who are actually, you know, describing a little bit their views of the learning process. And the problem is that as professionals, we encounter the routine problem that we do automatically, as described by Francesca, and then we have a case that is a bit more challenging, for which we go find the information we need, and then we continue. And we have just enough that we can actually solve our immediate problem. And it's the same concept a little bit that Eero presented is in this area of paper that are based on actually observational study of workplace learning, where a lot of the learning that occurs is implicit. We don't even think about it, meaning we don't really reflect on it. Some of it is reactive when we encounter a problem, and a minority of it is really deliberate. And the problem with that is that it's often superficial, and some of the unconscious learning might not be good things to be learning, and we might be learning bad habits. And essentially, in medicine, we do a lot of individual learning or intraprofessional learning, whereas most of what we do in our practice is actually collective. So again, in practice, not really active, not self-directed, maybe not that reflective. And it's astonishing to me that all the stuff that we know works for undergrad and postgrad, like active learning, practice, role model, feedback, we just don't do that at all in continuing professional education. So I have 20 seconds left, so I'm going to go through this pretty quickly, but that's okay because I don't have much to say because there's so little literature about what we should be doing for continuing professional education that it's going to be pretty short. But a couple of big concepts. I think it's really important to actually increase our opportunities for formative assessment and individual data performance, because that allowed us not only to come up with better learning plan, but also provide collective data of how you're doing as a group, and that can also inform the development of bigger or collective professional activities. And that was just to illustrate the surveys that we did for the society. And just, I guess the highlights is that very few people had engaged in assessment type of CPD activity over the last year, and the major issue is that there's a lack of access to those activity of high quality, but certainly not a lack of interest to engage. I'm going to skip that part. So a couple of ideas borrowed from the literature of undergrad and postgrad, and coaching as it's a huge popularity, like very popular concept. Not that we really know what it means, even at the undergrad or postgrad. I think it's kind of a work in development, but this idea of someone who's there for your learning, even once you're past certification, thinking about a way of structure, curricula, and guided communities of practice. And integrate into all this some team-based and interprofessional learning, because really, as I said, our performance are really much collective. So, just a summary of how these three key players can influence each other here, but really the idea is to convince you that we really need to pay more attention to continuing professional development. We cannot assume that it happens automatically, and for the greater good of our patient, we would really need to focus a bit more on that. Thank you very much.